So, hello, my dear students. Welcome to my YouTube channel. Today's topic is Lecture 2 in Physiotherapy in Medical and Surgical Conditions. So, this is the second lecture in Medical and Surgical Physiotherapy. In the first lecture, we had seen about burns. In the burn topic, we had seen about the role of skin, various sensory receptors, layers of skins, and types of burns, including subclassification of thermal burns. So here I would like to revise briefly the first lecture, what we had discussed. We had discussed role of skin. Second, various sensory receptors. Third, layers of skin. Fourth, types of burns. And epidemiology of burn. And fifth, subclassification of thermal burns. The subclassification of thermal burns had superficial thickness burns. Yes. Superficial partial thickness burns. Deep partial thickness burns. Full thickness burns. And subdermal burns. So this was the classification what we had seen in our first lecture. Yes. So this is what we had learned in our first lecture. Lecture. Now we had seen that superficial partial thickness burns. It is the very mildest forms of burn, like your sunburn. Deep partial thickness burn, the hallmark feature is edema. And from superficial partial thickness burns, you may start seeing blisters. Yes. So as you progress with the burns, you may see blisters, and in subdermal burns and in full thickness burns, the vascular structures and the muscular structures are also involved. So in full thickness burns, it's all the whole dermis is involved. Okay. Whereas in superficial thickness burns, only the certain part of dermis is involved. So now in today's lecture, we are going to discuss about the electrical burn. Okay, so before we move on with the electrical burn, I would like to briefly revise the same topics of thermal burns, so that in a video format, so that everything is very much clear regarding the burns, because this is very important topic as far as physiotherapy in medical surgical condition is considered. So let us see a nice video regarding this.
So we're going to focus on the different types of burns, the most dangerous ones, as well as the pathophysiology as well. So let's begin by recapping the normal skin anatomy. So here's a section of our skin. We have three layers of the skin, obviously. The epidermis on the very top, the dermis, which is further divided into the papillary layer for your fingerprints, and then your reticular layer.
Yes. So what here it has been described, that you have the topmost layer as epidermis and the second layer is dermis. The first layer of dermis is papillary dermis, and the second layer is reticular dermis. So you can see the major portion of the dermis is your reticular dermis.
And then you have the hypodermis, also basically what is known as fat.
The layer below the dermis is known as hypodermis.
Hypodermis is not really
or subdermal
skin layer. Now the epidermis is very thin, and interestingly, its only blood supply is at its base. The epidermis is what essentially part of your skin that sheds off every day or so. What happens here is that the cells at the base of the epidermis, which are sitting on the basement membrane, receives blood supply from small capillaries from the dermal layer of the skin. And so this allows the cells of the epidermis.
So here it has been described that the blood supply to the epidermis is through small capillaries located in the dermis region. Yes, so this is what it has been described.
Nutrients and to divide while moving up. As the cells divide and move up, they get less and less blood supply until they die essentially, and that is why you have thin skin on the top of your skin. Other important structures which make up the skin anatomy itself are the hair follicles, which help in sensation and indirectly in heat regulation and lubrication. The main arteries and veins that supply the skin really supply the hypodermis and dermis, and then the smaller capillaries branch off and supply all the way to the base of the epidermis. There are also many sensory nerve endings of the skin important in sensory aspects such as detecting pain, heat, and pressure. Finally, it is important to mention the glands. Now, glands around the skin help in lubrication, as well as releasing antimicrobial substances and heat regulation. However, it should be pointed out that we normally have what's called opportunistic organisms, opportunistic bacteria living on our skin. Damage to the skin, such as a cut, can thus introduce bacteria to this area, causing problems. Similarly, if a person suffers from a burn injury, it can introduce bacteria and other organisms such as fungi easily into the body and can cause significant problems. So what are burns? Well, burns are injuries to tissues caused by heat, friction, electricity, radiation, or chemicals.
So
there are
this
many
is
types of burns,
what we have discussed.
Inhalation burns.
Yes, the thermal burns. Yes, so majority of time, when you have a heating object, yes, causing the burn, you have an inhalation burn also accompanied with it. So whenever you have thermal burns, majority of time you have an inhalation burn accompanying the thermal burn. So they are correlated with each other.
Particles of smoke. Cold exposure, like frostbites, are also burns.
Yes.
Radiation burns, which include UV radiation from the sun. Usually, people go to hospital for any of the burns mentioned above. However, there are some burns which require transfer and referral to a special burns unit because of the complications that may come with them. And say include chemical burns, electrical burns, and inhalation burns, which are already.
So here it has been described that when to refer to the burn center, it is obvious when the degree of severity is more. Yes, severity of burns is more. Severity of burns is more, and in case of chemical burns, electrical burns, and inhalation burns, it is by default that you are referring it to the burn center. Is it okay? Clear about this?
So let's learn a bit more about the pathophysiology and the mechanism of disease. When a burn occurs on the skin, it causes changes within the skin.
So this is what the Jackson model is that we will discuss in our
zones. These zones
Lecture number 3
were described by Jackson in 1947, and so it is also called the Jackson model. The first zone is the zone of coagulation. Then it's the zone of stasis on the outside, and then the furthest part is the zone of hyperemia. So the zone of coagulation is essentially the point of maximum damage. In this zone, there is irreversible tissue loss due to coagulation of proteins. Thus, you get coagulative necrosis. Surrounding the coagulation zone of necrosis is a zone of stasis. Now, in this zone, it's essentially characterized by decreased perfusion. This ischemic zone may progress to full necrosis unless the ischemia is reversed. At the very outside is the zone of hyperemia. In this outermost zone, tissue perfusion is increased. The tissue here is invariably recovered unless there is severe sepsis or prolonged hypoperfusion. Again, the stasis zone is characterized by ischemia and may progress to full necrosis unless the ischemia is reversed.
So in this case, there are 3 zones. Okay, burn wound zones. Zone of hyperemia, which is the less severe zone, zone of stasis, and zone of coagulation. The zone of coagulation is the maximum damage zone. Yes, there is irreversible damage. So we are in the case where we have coagulation injury in the zone. Yes, there is irreversible tissue loss. So what we need a skin grafting. Skin grafting is required for the healing. Clear. Whereas in the stasis zone, it is there is a characterized by decreased tissue perfusion. There is tissue perfusion, but there is decreased tissue perfusion. Yes. So if not taken care enough, it may go to coagulation zone. Okay. So we will quickly revise. We'll discuss this in our lecture number 3 in detail.
So that is a general thermal or radiation burn, deep burns. So let's zoom into the skin here to look at what happens in a superficial burn, what happens in a deep burn. Let's take a look at a superficial burn first. If it's a superficial burn, it will cause damage to the epidermis and the upper dermis only. So like
yes, so superficial burns only cause damage to epidermis and part of upper dermis.
Superficial burns will damage the keratinocytes, which are your cells in the epidermis, and will also activate an immune response. So activate immune cells around the area, such as mast cells and macrophages. The damaged keratinocytes, the mast cells and macrophages, will secrete pro-inflammatory cytokines, triggering an immune response. The cytokines will stimulate nerve endings around the dermis. The sensory nerve endings here can be the ones that detect pain, for example, and pain is an important feature of superficial burns. Some cytokines will cause increase in vascular permeability. The increase in vascular permeability will cause fluid to leak out and may lead to interstitial edema. As the fluid leaks out, it can result in hypotension. Remember that the increase in vascular permeability causes fluid to leak out. The fluid can actually accumulate in one area, causing a blister on the skin surface. The sensitive blister can rupture and release fluid onto the damaged skin surface. Thus, superficial burns have a moist appearance. The cytokines secreted by the cells above will also cause concurrent vasodilation, causing further hypotension in severe cases. The vasodilation contributes to the warmth in the area, as well as causing blanching of the skin and erythema. Blanching means that when you press on the burnt skin surface, blood will quickly fill it up because of the increase in blood flow to the area. The blanching skin is a feature of superficial burns. In deep burns, you have more than just damage to the epidermis and the upper part of the dermis. You have damage all the way down, extends all the way to the hypodermis, so it's a pretty deep burn. Deep burns can thus damage blood vessels in the skin. Because you have damaged blood vessels, everything will leak out. You have no blood supply to the area. So you eventually get this dry, non-blanching surface. It is dry and inelastic. The non-blanching dryness is an important feature of deep burns. Further, deep burns extending to the reticular layer of the dermis can destroy nociceptors and other sensory nerve fibers. Initially, pain can be detected, but as the sensory nerve fibers are damaged, you get hypothesia. So you get reduction in sensation. Loss of sensation is an important feature of deep burns. Obviously, not all your blood supply is damaged or your blood vessels are damaged. The function of blood vessels will react to the cytokines produced around the area. The vessels will increase vascular permeability, which will cause fluid to shift out, causing interstitial edema. So fluid shifts out from the intravascular space, so the blood vessel, and this will into the interstitium. And this huge amount of fluid coming out of the vessels will result in hypotension, so circulatory shock even. Hypotension as a result of the shift of fluid occurs more in deep burns rather than superficial burns. So now that we know the pathophysiology of superficial burns and deep burns, let us learn a bit more about classification of the burn depth. Divided into superficial epidermal burns and superficial partial thickness burns. In superficial epidermal burns, only the epidermis is involved, so the very top of the skin. The most common cause here is your regular sunburn.
This is what we have discussed.
Which is painful. The epidermis layer is the only layer involved. On a side note, superficial burns are not included in the assessment of the total body surface area burn. In superficial partial thickness burn, you are causing damage all the way to the papillary layer of the dermis, so the upper dermis. And so because you are going all the way to the upper dermis, you are allowing the blood vessels to increase permeability into blister formation, which then can subsequently rupture. The feature of the burn is red, moist, weeping with rupture and unruptured blisters. The burn here is very painful. Again, in superficial partial thickness burns, your epidermal and papillary layers of the dermis are involved. The important features here are blister formation, rupture of blisters causing a weeping, moist injury. As mentioned before, and I'll mention this again, superficial burns is characterized by blanching injury. So when you press your finger on the area pressure will return to its normal color because of the normal perfusion. The other important aspect of superficial burns is that the sensation is still working. It is normal, and so you feel pain. Deep burns are totally different. Deep burns involve all layers of the skin. The important feature of deep burns is that it does not blanch with pressure, and there is minimal to no pain. No sensation due to damage of nerve endings in the area. Deep burns can be easily divided into deep partial thickness burns and full thickness burns. In deep partial thickness burns, the burns are partially deep. They cause blisters which easily rupture and come off. The surface of the skin can be pale if blood supply is lost, or red if there is extravasation of red blood cells. In partial deep thickness burns, you can get damaged blood vessels, which means when you press the skin surface, it will be not blanching. And also, partial deep burns may damage sensory nerve fibers, causing a decrease in sensation. In partial deep burns, the skin layers involved are the epidermis and all the dermis layer. Full thickness burns are the worst. Here, all the skin layers, including the hypodermis, are involved. The burn is so extensive that the skin may look waxy white, leathery gray, or charred black, depending on how deep it is, duration of the burn, etc. The burnt area is not wet because no blisters are forming. It is usually dry and inelastic. The sensory nerves and the blood vessels are definitely destroyed, and so you have no sensation and no blanching. In full thickness burns, you have destruction of all skin layers, including the hypodermis. There's actually a fifth classification of deep burns, but we're not going to talk about it here because I feel like it causes more confusion than help.
So the layer,
a burn.
So the apart from full thickness burns, there is the fifth classification, which I would like to mention, is the subdermal burns, which involves all the muscles and bones and it causes necrosis.
To the burns unit is very important. We talked about referring certain types of burns to the burns unit, such as chemical burns, electrical burns,
and
inhalation
burns.
But how about the burn depth?
Yes. So this is what we have discussed about our topic in the lecture 1, and we have also discussed the same in our revision today. Clear? So yes. So now moving on towards electrical burns. Now, as the name suggests, the burns which are caused by electricity, they are known as electrical burns. Okay, the burns causing because of electricity. So, on what purpose or how the burns are classified, or what will be the burn severity? It will depend upon type of current, whether it is an AC current or DC current. Yes, AC current or DC current, AC or DC current. Yes, intensity of current. Yes, what was the intensity of current? How uh, what was the voltage of the current? Yes, that will also differ, and the area of the body involved. So if it was a DC current, yes, the severity of burn may be more. If more the intensity of the current, more severity, and larger the area involved, larger the intensity. Clear? So with this, we would move forward. Electrical burns occur due to the passage of electrical current through the body after the skin has made contact with the electrical source. So then and then only the electrical burn will occur. Yes. So when there is a source of electricity, whether it is lightning or our AC/DC currents, when the contact between the body and the electrical source is there, then and then only the electrical burn occurs. So if there is a contact, there are two basic points to look after in electrical burns. That is the entry point and the exit point. Yes. Yes. So this is very important. The entry point, which is smaller compared to the exit point, always make sure that entry point is smaller compared to the exit point in electrical burns. So this entry point, yes, it is always charred and depressed, smaller, yellow and ischemic, whereas the exit point is in explosive type. So it is larger, dry, necrotic, and arterial spasm is there, and tissue viability is very poor. So wherever the area is larger, that is the exit point. Clear? And wherever the area is smaller, that is the entry point of the electrical burns. So moving ahead, what can the electrical burns can cause? The electrical burns can cause cardiac arrhythmias, ventricular fibrillation, respiratory arrest, renal failures, acute spinal cord injuries like spastic paralysis. So these are some complications of electrical burns. So this is what we had to discuss in today's lecture. Okay, so we have already discussed regarding the thermal burns, the basic type. Okay, what we have to discuss is electrical burns. In electrical burns, it depends upon the type of current. Second, intensity of current. Third, the area of the body involved. And you have an entry point which is always smaller compared to the exit point. So this is the take home message from today's lecture. Today's lecture was basically a revision lecture regarding thermal burns and electrical burns. Yes, so It is very important to understand that how the burns are classified and on what purposes the burns are there. So please feel free to ask me any questions at the end of the. Yes, thank you very much. And you can drop message in this. I'm very poor at drawing. Please bear with my drawing. I know. Okay. Thank you.